Good afternoon. My name is Dr. Alan Ettinger, and I am an adult epileptologist. I have the pleasure of being the first speaker in an educational event for neurological surgery, PC. Before I begin, though, we have a very special person joining us, Mr. Tom Hopkins, representing the Epilepsy Foundation of Long Island, now known as EPIC. And I've had the proud opportunity to work with Mr. Hopkins in the local and the National Epilepsy Foundation. So it's only natural, as the spirit of the Epilepsy Foundation is patient education, that we bring Mr. Hopkins up to the podium just to say a few words.
I commend everybody for coming out this afternoon. Education is what it's all about. To the extent that you educate yourself about epilepsy, it puts you in such a much better position to choose places to get treatment and to talk to your doctor about treatment options, and also to think a lot about what supports you need and think about how epilepsy impacts your life and your lifestyle and all those other things. This organization, Alan's organization, they are excellent folks. They're very competent. They provide good quality care. My organization, EPIC Long Island, the Epilepsy Foundation, we provide education, we provide support, services like that. If you'd like to find out anything more about my organization, I'm here along with a couple of my staff, Irene Rogers and Janet Romeo in the back. I think they're probably known to many of you already. So with that, thank you very much, and it's a pleasure to be here.
Thank you very much, Tom. I'm going to introduce Dr. Brian Snyder is now going to join us. Dr. Snyder is an outstanding epilepsy surgeon with extraordinary experience in the field of epilepsy surgery, and I've had the pleasure of working together with him and the epilepsy team, and I'm delighted to bring him up to the podium.
Epilepsy is a complex disease that requires a team to take care of you effectively and properly. So I don't make decisions on my own, and rarely do the other members of our team. We consult each other, we present patients, and have conferences every single week to try to identify patients for surgery, to identify patients that may benefit from novel other treatments, other trials, and to sort of direct care in the most comprehensive fashion possible. So I direct the functional and restorative neurosurgery program at Winthrop, and this is epilepsy, movement disorders, pain, and psychiatric illness. Well, how do those things relate? Just because people ask that question frequently, all these diseases to some extent are diseases of neural circuitry rather than one specific area in and of itself. So epilepsy, for instance, for a seizure to spread or to develop into a seizure, some area needs to discharge, and that needs to spread somewhere, right? So all these diseases can be treated in similar fashions at times that involve disruption or severing of different systems in the neural circuitry. So again, what's a seizure? It's an abnormal and excessive synchronization of a population of cortical neurons. Well, what does that mean? It means the neurons start behaving the same way at the same time, right? Our nerves in general are sending information. So one nerve is sending one type of information to one area, et cetera. What happens here, sort of like the wave at Giant Stadium, right? All the cells are doing the same thing at the same time, and a wave of electricity is spreading through the brain. And then epilepsy is a tendency towards recurrent seizures and unprovoked by any systemic or acute neurologic insult. So we don't think of patients of having epilepsy if they have seizures frequently due to hypoglycemia for diabetes in the absence of anything else or other things like that. And again, this epilepsy affects 1% of the population. So we're not talking about some rare disease here. We're talking about a disease that is relatively common, and despite that, it can be very frustrating for you and for us that the treatments aren't even better than they are. But we're working with you to try to figure out the best thing that can be done and what could be done in the future. And this is the second most common neurologic disease. It's common in all age groups, and it has significant, at times, devastating consequences. Satisfactory seizure control is not obtained in 30 to 40% of patients. So there are some people that can have epilepsy that they can take a medication and they're done. You know, I mean, they may have to take the medication, but they have good seizure control. Unfortunately, there are a significant number of people that's not the case. And about 300,000 patients in America have medically refractory partial onset seizures. About 200,000 of those we think would benefit from surgery. About 1,500 of these operations are done in America every year. So why is that? Why are we operating on so many fewer people? Well, I think there are a lot of reasons, and I think that's beyond the scope of answering that question completely today. But I'd like to say one of the reasons I think is while people are afraid of having surgery, and I don't blame them. I mean, brain surgery is a scary thing, and it should be scary, but so is a lifetime of seizures. And I think the risks of seizures over a lifetime we've seen and established is more dangerous than the risk of surgery. I think there are other reasons too. There are limited numbers of centers that have experience doing the surgery. There are a limited number of neurologists that have experience assessing for the surgery, et cetera. So what causes epilepsy? In about 70% of patients, we don't know. In 30%, it may be something we can pinpoint or identify: a head injury, an infection, a tumor or stroke, a genetic problem or other hereditary problems, and or problems that occur before birth. So what happens during a seizure? Well, what happens is, again, we have this spread of electricity. So a generalized seizure involves the whole brain and loss of consciousness. And there's several different types. I won't belabor this, but there's something called absence seizures, something called tonic-clonic seizures. And then what are the opposite of generalized seizures are partial seizures. And what is that? This is only involvement of that electricity in one area of the brain. It may or may not include the loss of consciousness. And the symptoms are related to the area of the brain that electricity is spreading through. And obviously, partial seizures can generalize secondarily as well. So there are a lot of ways of breaking down what type of seizures you may have. You know, there are people that, you know, we talk about how people classify things. There are lumpers and splitters, right? There are people that keep dividing things until they say, you know, everyone's very different. And then there are people that start putting people into different boxes. But anyway, we can classify partial seizures or generalized seizures. And it's important to remember, again, that the brain, different areas of the brain, subserve different functions. Well, why is that important to remember? Well, it's important for us to remember because it allows us to start to take an educated guess where your seizures are coming from, just knowing what the semiology or what the appearance of your seizures are, right? So people that say, well, the first thing I notice in my seizures is my left arm twitching. Well, that may give us a clue. It may be coming from the motor area. If you say the first thing I notice is a funny tingling or buzzing. Well, these are not invariable, but that may suggest it's coming from the sensory area. So again, specific areas of the brain subserve specific functions. So then what's the starting point for looking at seizures? Well, it's something called an EEG, right? This is something that demonstrates the electrical activity recorded from the scalp. And it's probably the most important primary study for the diagnosis, prognosis, and treatment of epilepsy. And at times, you may have video EEG. So we may put a TV camera and watch you. Well, that gives us more information. We can see what's happening then. You may have this for a long time. We may watch you for a longer period of time to see that all your seizures look the same, et cetera. Usually with your first seizure, and I'm sure those of you that know people with epilepsy or are patients with epilepsy, this part of the workup's been done, but you're going to have had a history in physical, blood tests. You may have a spinal tap if an infection were suspected. You may have blood or urine screening if someone was concerned about some sort of toxin. You may have an EEG, and you may have imaging of your brain. So who are we going to think about operating on? Well, we're going to think about operating on people that continue to have seizures despite 2 first-line medications, and those trials can last 3 months to even several years. That doesn't mean once that's happened, we're immediately rushing you to the operating room, but we know from experience if 2 medications don't work, it's rare that adding a third, a fourth, a fifth, et cetera, is going to work. So what we're going to do is start to get you down the highway towards some other treatment. It doesn't mean we're not going to continue to try those medications, but we know from experience, our experience and experience throughout the country and the world, that if 2 medications don't work, the chance that a third or a fourth is going to work is really under 1% usually. But we'll keep trying. And again, greater overall benefit is realized when patients have surgery earlier. Despite that, patients take many years in general until they're even referred to a center that does surgery, let alone to a surgeon. Well, if you're going to come for a pre-surgical evaluation, again, we're going to review the same things again, a history and physical, EEG, imaging. We'll have pre-surgical testing. Obviously, if you have a bad heart or something else, those are things we need to be aware of. We're going to do neuropsychological evaluation, and Dr. Klein will talk more about that. I think I have one more slide about that. And we're going to conference on you. So it's not going to be, I'm not going to see someone and say, oh, I think you should have blah, blah, blah. The team together will decide what we think our recommendations are. In the end, of course, you're part of the team too, and you're going to have to chime in, and we're going to direct your care based on what your needs and wishes are as well. So we may get more pictures. We like pictures a lot. So there are different types of pictures. We might get MRIs. We might get PET scans. We might get SPECT scans. We might get functional MRI, which is also called fMRI. And what are these different pictures? Well, there are different ways of both looking at the structure of the brain. So what does it look like? Are there areas that are atrophied or shrunken? Are there areas that are swollen or edematous or other things? And then it also gives us some idea of the behavior of those areas. Are there areas that are hypermetabolic, that are very active? Are there areas that are very quiet? Well, we can learn a lot from these images. So then you will have neuropsychological testing. And again, Dr. Klein will talk more about that. But neuropsychological testing identifies deficits in attention, memory, language, visual spatial ability, and executive function. Well, why are we going to do this? Well, one, we want to know how your mind's working before surgery. But two, again, subtle deficits or problems in any specific area may give us another clue where the seizures are starting from. So ultimately, one of the most important things to say is, well, where are they coming from? Because if we know where they're coming from, we're a long way towards knowing whether or not we can treat you surgically and towards directing surgical treatment. So you may have a Wada test. And what is a Wada test? A Wada test involves putting one half of the brain to sleep, or even a smaller part than that at a time, while the other half is awake. Again, gives us an idea of certain important questions we need to answer. Is memory good on both sides of the brain? Because memory can be good on both sides or just one side. And is language on both sides, one side or the other side? These may have clinical significance. We don't want to hurt you during surgery, of course. And it may, again, have diagnostic significance. When we see one area not functioning well, usually that's the area that the seizures are coming from. So again, team approach. Once we get our workup, and midway through our workup and at different points, Dr. Ettinger will present the patient. He'll discuss all the important parts of the seizures. We'll look at video EEGs. We'll look at what happens during a seizure. We'll look at what happens between seizures. We'll look at all your pictures with a neuroradiologist. Dr. Klein will talk about the neuropsychological results. I will chime in on the surgical risks, the ability to access the area, et cetera. And then we'll together come up with a group consensus. We'll talk to you some more, and we'll try to come up with a plan that will work for you. And again, usually in our first conversations are not procedures to treat your seizure disorder, but unfortunately, more procedures to diagnose your seizures more effectively. So scalp EEG has been compared to listening to a radio with a pillow over it. So what sometimes we need to do are operations to get closer to the noise, so to speak, to the EEG. So we may have to do operations to put wires directly over the brain so that we can precisely pinpoint the location of your seizures. And again, surgery can be defined as curative or palliative. Well, what is curative surgery? It's surgery that we think can cure you of your seizures. What is palliative surgery? Well, based on one reason or another, we don't think we can cure you of your seizures, but we think we have an operation that can decrease the frequency and or severity of your seizures. So there are a lot of operations we do. I'm not going to go through all of these, but we can do temporal lobectomy, so we can cut out areas of the temporal lobe. We can resect areas of other areas of the brain. We can sever areas that are causing seizures. We can stimulate areas of the brain, etc. Again, our goals of surgery are seizure freedom without any new problems, right? We're not going for broke, right? The goal is not we'll make you seizure free, but something horrible might happen. The most important thing is taking care of you as a patient. When we can get seizure freedom, we're gonna do that. When we can't, we're gonna do whatever is safest to take care of you as a patient. When we know improvements of quality of life correlate with seizure freedom. So again, surgery. So the type of seizure and the location tell us what to do. It's rarely really something that we're just going to pull out of a hat, but we're going to have to sort out all the details. When we can, we want to resect abnormal areas of the brain. When we can't, we're going to do something else. So temporal lobe epilepsy, this is probably the most common type of seizure disorder. In subsets of patients, 60 to 70% can be seizure free, and with 20 to 25% with rare seizures and 5 to 10% with minimal or no improvement. So 80 to 90% have significant improvement, and 30% of those who are seizure free can completely stop taking their seizure medication. So sometimes, again, there are many operations, and my talk today is not designed to review with you the results of the 30 different surgeries I do. It's more to touch on the different types of things we do. So temporal lobectomy can be considered the prototype of a resective operation. So when we can, we're going to take out the abnormal area. Well, we're not going to take out an abnormal area if that's going to neurologically devastate you or hurt you. So the results obviously are better when we can take it out than when we can't. When we can't take it out, we have other options. Well, we can do vagus nerve stimulation. This is an outpatient procedure. You'll go home the same day. We can put an electrode on the nerve in the neck and connect it to a pacemaker. I think my slide is outdated. This is 50,000 of these have been performed. I think it's significantly higher. Seizures can decrease by as much as 70% in general, but about 10% of patients are seizure-free, and you may have improved quality of life with that as well, decreased depression, et cetera. We can also do brain stimulation for seizures if we can't take the area out. So very recently, something called responsive neurostimulation was approved to treat seizures that are not amenable to resection. So some patients are told, we can't cut this area out. We think you'll get hurt. We don't want to hurt you. So this involves putting electrodes in the areas of the brain to detect the seizures and other electrodes to interrupt or prevent the seizures. And this allows us to treat more patients with epilepsy than ever before. Deep brain stimulation is currently approved as a technique to treat other diseases, and this procedure may also be approved for use in subsets of patients in the near future. So technology in the future. So, it's frustrating to have a chronic disease that sometimes you can't be offered the best possible outcome. Well, I think that in general our philosophy is to, one, obviously to do no harm, two, to really use the most cutting-edge techniques available to do what we can, and to always be thinking about what may be on the horizon. So we're always adjusting our techniques to be safer and to use more advanced techniques. We use, at times we might think about using radiosurgery, which is gamma knife or cyber knife. Use the microscope when necessary, lasers when necessary, to aid in the safest and most minimal resection, so to do as little to get as much as possible. And we always work with a team of skilled nurses, physical therapists, social workers that aid in your transition and recovery from every step in your treatment. So in conclusion, epilepsy is a common disease and it affects 1% of the population. Medical therapy, which is first-line treatment, doesn't work in 30 to 40% of patients. And those patients all should be seen by someone like Dr. Ettinger. When possible, curative surgery can have results of 60 to 70% seizure freedom, and other patients may be candidates for palliative surgery or neuromodulation. And every couple months there's something new we're thinking about. And when available, there are new things we're introducing into our repertoire. So it really does take a team to do this and to do this right. I appreciate being able to speak with you. if there are any questions, I guess we'll hold them till the end is the plan. So I have the pleasure and honor of introducing Dr. Klein, who is our esteemed neuropsychologist. And he gives us a glimpse into how your mind works. So I'm going to let him speak next. Thank you.
So, as Dr. Snyder said, my name is Gad Klein. I'm a neuropsychologist. I work with NSPC. My goal today is a couple of things in my brief talk is to, first of all, explain to you a little bit what a neuropsychologist is. More people are familiar with what a neurologist is, with what a neurosurgeon is, but not as many people are necessarily as familiar with what a neuropsychologist is. And so I wanted to kind of give you a sense of what I do for the team, and then also kind of walk you through the services that I provide both in the surgical context of epilepsy and in the non-surgical context of epilepsy. So, what is a clinical neuropsychologist? Well, you can read this as I'm talking, but the basic idea is a neuropsychologist is a clinical psychologist. We have a PhD, but our training, rather than in kind of doing supportive psychotherapy, is more related to brain and behavior. Our training is in the cognitive impact of neurologic disorders and neurologic diseases, anything from brain injuries to concussions to brain tumors to Parkinson's disease, and of course epilepsy, which is a neurologic disease that impacts the brain. So our expertise is kind of assessing both your cognitive functioning, your thinking, as well as how that impacts on the psychological aspects, such as mood. So, you know, Dr. Snyder mentioned this briefly, but a basic neuropsych assessment in epilepsy can sometimes be a little bit lengthy. The reason it's lengthy is because we really want to get a good assessment of general cognitive functioning. The goal here is not just to find out an IQ test. We don't do IQ tests. We're not really so concerned about your overall intelligence level. We're much more concerned about specific cognitive processes that the brain does, because those specific processes are controlled by specific parts of the brain. And as Dr. Snyder mentioned, in terms of epilepsy, that's very often important because it helps us figure out where these seizures might be coming from. So, of course, you know, we'll do a presenting problems, social and educational history, psychiatric history, functional ability, and then, of course, we go into the cognitive assessment. Things like language, concentration, spatial skills, planning and organizing, memory, attention, speed of thinking or processing speed, problem solving. Our brains do a lot. We take it for granted quite often because we don't break everything we do down on a day-to-day basis to these functions, but that we do all of this stuff all the time, and our brains are constantly working. Now, depending on the type of epilepsy you have, the place where the epilepsy is coming from, the age at which you got epilepsy, and various other factors, you can have certain cognitive issues, cognitive deficits, cognitive weaknesses. Sometimes they may be mild, sometimes they may be more severe. These cognitive deficits can range for things such as memory, recall and recognition things, remembering, let's say, remembering what you did last week, remembering your doctor's appointments, remembering to take your medications, remembering you got to pick up your kid at a certain time, that type of memory, okay? It can also impact on attention, your ability to work for long periods of time, to jump back and forth between different topics, to stay focused, language, word finding difficulty, kind of tip of the tongue phenomenon, and that goes for both names of people who you know very well, but they don't pop in, and also when you're talking in conversation, sometimes patients with epilepsy just can't find the right word to say. They get a close word or they can't get the word, so they have to restart again, something that happens quite often. Depending on the epilepsy, visuospatial perceptual deficits, rapid processing of the information that's going around you visually, and also executive functioning. And executive functioning is a very large cognitive area, but the higher order cognitive functioning, planning, jumping back and forth between tasks, organization, problem solving, all of these higher order cognitive functions that as human beings we do can sometimes be affected in epilepsy as well. So, you know, these are various examples of the tests we give. Most of the tests that I do are paper and pencil, interactive with the patient. There are some that are done on the computer, but the truth is it's been shown that the paper and pencil interactive testing is very important because it allows me a chance to see not only the score and number at the end of the computerized test, but also the process, the way the person is doing that particular task, how they're making their errors, where they're making their errors, and that helps me figure out exactly what's going on. So we may ask you to draw lines between between numbers, identify pictures, judge orientation of lines, do tasks where you kind of have to rapidly inhibit your responses or rapidly process things, those various types of cognitive tasks. And obviously we have a large arsenal of tasks that I can choose from, and each of those are explained to the patient when they're in the office and they're about to undergo them. So we're not going to spend much time on this because it can be a whole talk in and of itself, but the basic idea is that different parts of the brain control different functions. Especially in epilepsy patients, this is critical because if epilepsy is coming from a specific part of the brain and they've had it for a very long time, well, that patient's area of the brain that controls specific things may be somewhat different than we would typically expect in somebody who hasn't had epilepsy for a long period of time. Because that epilepsy, that abnormal firing, as Dr. Snyder and Dr. Enger mentioned, in the brain can sometimes cause the brain to shift things to different areas or move it away from where the seizure focus is in order to preserve that function as much as possible. And so we always want to make sure that we're looking at frontal lobe functionings, like I said, formulating, planning, behavioral inhibition, speech is very critical on that side of the brain. The temporal lobe, as Dr. Snyder mentioned, the standard surgery, very important for memory function and even for naming and other language functions. The parietal lobe is very important for spatial perception, sensory function. The occipital lobe is mainly important for visual processing, but sometimes patients have seizures coming from further back. And the cerebellum itself, that area which is thought to be just motor function, really has a lot to do also with mood and cognitive processes as well. So there's a lot of different areas of the brain that control a lot of different things. And that's why the neuropsych evaluation can be, in some cases, quite lengthy. Well, not everybody with epilepsy has cognitive difficulties, okay? And a lot of people do not have cognitive difficulties. But what are some of the major predictors of cognitive difficulties in epilepsy? Well, number one, the duration of the epilepsy. So how long you've had seizures, okay? The number of drugs that you're on, the number of anti-epileptic medications that the person is being treated with also makes a difference. Unfortunately, the drugs that are very effective at controlling seizures in a lot of patients, those can sometimes have negative cognitive impact, not always, but sometimes. And especially if you're doubled up and you're taking 1, 2, even 3 medication, the risk of cognitive difficulty kind of increases. The history of status epilepticus, of how long you've had lengthy seizures for that has not been, for over a period of time, not just 5, 10 seconds, but lengthy kind of seizure activity in the brain, and a larger amount of generalized tonic-clonic seizures or the grand mal seizures. The more the patient has of that, the more chance there is of having cognitive impairment, because that type of seizure really kind of affects the entire brain. It's not really focal. It doesn't stay in one area. Another area that sometimes tends to get overlooked in epilepsy, but not in our center, Dr. Ettinger is very, very involved in psychiatric issues in epilepsy, and I am as well, is that patients with epilepsy tend to be more prone to depression, and vice versa. Patients with depression, for some reason, tend to be more prone to developing epilepsy. That doesn't mean it always happens, okay, but the numbers sometimes go up. 72.9% of patients with depressive disorder have also had an anxiety disorder, and sometimes patients in epilepsy have anxiety because of everything that they're going through, whether it's the medical trauma that they've been through, whether it's the anxiety that the seizures are causing, whether it's the anxiety that going out in public and possibly having a seizure may cause. All of these things contribute not only to your mood and to theoretically depression, but just to generalized anxiety, okay? What it's shown is that a lot of quality in life in epilepsy, and this is only in all neurologic disease, but also in epilepsy specifically, has to do a lot with mood, okay, with how you're feeling, how your quality of life is, rather than what type of seizure or how severe it is, okay? And that's why the mood is critically important, and anxiety is critically important, because that can impact severely on quality of life. And in some patients, they'll come into my office, and when I ask them what's bothering them, they will report mood changes and anxiety changes as more bothersome than the actual seizures themselves, okay? And that's why it's critical that this be assessed. And when you come in for a neuropsychological evaluation, I put on not the neuro hat, but the psychology hat. And obviously, this gets addressed very, very proactively and strongly, and appropriate referrals are made if necessary. The neuropsychologist is also very involved in the pre-surgical evaluation, and in a couple of steps, and I'll show you where. The initial one is the neuropsychological evaluation, which is done obviously in the pre-surgical workup, but can be done in any epilepsy patient who is having cognitive difficulties or complaining of cognitive issues, and then we can kind of see what the issue is and make recommendations to the treating physician. Maybe we have to look at the medications, maybe we can do other things to kind of improve that cognitive functioning. But in the pre-surgical evaluation, certainly we want to do neuropsychology because it can help us focus the specific area of the brain where the seizures are coming from. If memory comes from the temporal lobe, which we know, and we see that, hey, you're having trouble with memory, but not with really anything else, well, then that might give us a clue that the primary seizure focus is coming from the memory area or the temporal lobe, and we can kind of look more closely in that area. And that would go for any other specific type of cognitive function, because we know which part of the brain controls that function. The Wada procedure, which Dr. Snyder mentioned, and we'll talk about it a little bit more in a second. Functional MRI, which we'll also talk about a little bit more in a second, and stimulation mapping. Okay? And these are a little bit higher, kind of more technological, fancy techniques, which are critical not only for helping us figure out where the seizures are coming from, but ultimately doing whatever surgical procedure needs to be done in the safest way possible with minimal morbidity and minimal side effects afterwards. So very quickly, what is the Wada test? Well, you see a picture here, and it doesn't work exactly like this, but there's a special physician we have, a neurointerventionalist, who injects medication, a very short-acting medication that allows us to actually put one side of the brain to sleep for a very, very brief period of time while still allowing the patient to be fully awake, fully alert, and answering my questions. And what that allows me to do is, instead of testing you in my office where hopefully you're using both parts of your brain, okay? And therefore I can't always tell which side of the brain the patient may be having difficulty with. In a case like this, we can actually shut off one half of the brain and test the other half of the brain so that we can really get very, very specific as to where the difficulties are, where the seizures might be coming from. And it sounds a little bit odd, but if anybody ever has to undergo such a procedure, obviously I walk you through this in minute detail. It is not nearly as weird as it sounds, but it is an incredibly helpful test for us quite often. Okay? The next one is functional MRI mapping, which we mentioned very briefly. What this is instead of just taking standard pictures of your brain like Dr. Ettinger mentioned, we want to know where in your brain these functions are controlled. Language, motor, visuospatial skills, because that's our goal, is to, again, figure out where these things are located, both for safety and to localize the seizures. So instead of just going into an MRI magnet and taking regular pictures of your brain, you go into an MRI magnet, and I make sure that they give you tests while you're in the magnet. You're looking at a computer screen while you're in the MRI. So instead of being bored and staring at the ceiling and falling asleep, you're actually looking at a computer screen. And you're doing neuropsychological tasks. And what that does is it changes the brain flow in the brain based on what task you're doing and what area of the brain controls that task. Well, that part of the brain gets more blood because it's more active. It needs more oxygen. It needs more glucose. And the magnet, the MRI, can not only take static pictures of the brain, but can also tell where the blood flow is going. And so what we do is we can do the neuropsych tests while you're in the scanner, and I can see exactly what part of the brain lights up. And in this particular case, what you see is we had an epilepsy patient. We wanted to figure out where language was in his brain. We did a language task while he was in the MRI scanner, and as you can see, one side of his brain lit up, and you don't really see anything on this side of the brain right over here. Everything is all on this side of the brain. And in this case, it looks like it's the right, but really it's the left. Just a trick of the MRI, okay? All of his language function was in the left side of his brain, which was good because if the seizures were coming from the right side of his brain, we didn't have to worry about hurting his language. And we can do that surgical procedure relatively safely and comfortably, knowing that he's not going to have any language deficits afterwards. Now, stimulation mapping, and this is something you'll see on those brochures if you pick it up. As Dr. Snyder mentioned, we often put those electrodes not only on the surface of your hair, scalp, bone, like you're kind of recording through a pillow, but very often those electrodes are put on the surface of the brain itself. Okay? Now, the problem sometimes is once they're put on the surface of the brain itself, we can't really see exactly where they are because we have to look through your entire brain. Okay? So one thing that we can do with the fancy technological techniques that I'm involved in is we actually can take that MRI of the brain and using computer modeling, remove the skull and actually make a 3D representation of your brain. This is not a fake. This is an actual person's brain. Okay? And then we see exactly where these electrodes are lying on the brain. And now, again, we know when Dr. Ettinger says, hey, there's a seizure coming from this electrode right over here, well, now we know. Not only do we have to guess, oh, it's somewhere in the frontal area, but we know it's exactly right in that area. And then what we can do is we can use those electrodes, like Dr. Snyder and Dr. Ettinger mentioned, to kind of map out exactly where your language is. So if we're concerned that there's anything important right in that area, well, we can just stimulate those electrodes and see if we get a response. Okay? And as you see over here, this arrow indicates motor strips. So we kind of stimulated those electrodes gently. There's a very gentle electric pulse that gets generated to the brain, doesn't cause any pain, doesn't cause anything. But if it stimulates your motor cortex, your hand may go like this. Okay? While you're fully awake, comfortable in your bed, with everybody watching with EEG. And therefore, we can map out almost very, very, very specifically where everything is coming from. And we can do it for language and motor function and visual function. Okay? The last thing we can do here to make it even fancier is, as you saw over here, right, we looked, this is the MRI magnet telling us where the blood is going in the brain so that we know where the things are. These are the electrodes. We know exactly where the electrodes are monitoring from the brain, and here we can combine the techniques. So if we see that that functional MRI told us that there's a lot of blood flow going to this area when the patient moves their hand, well, we can put that right on the same picture of the brain, and now we know exactly where to map with those electrodes. So we don't have to sit there for long hours mapping every single electrode. We can target it very specifically and once again increase the specificity of our findings, decrease the amount of time that the patient has to sit there with us in the room going crazy, and once again, of course, do this as safely as possible with no side effects and outcome. Again, the integration minimizes the patient discomfort, the time spent mapping, and the chance of triggering a seizure. So in summary, the clinical neuropsychologist in general epilepsy that can help determine the nature and cause of the cognitive dysfunction in the patients with epilepsy. Is it from the epilepsy? Is it from mood? Is it from something else? And appropriate interventions can then be planned. Okay? The assessment can also help determine the nature and severity of your affective symptoms or your mood symptoms and how they impact on your cognitive function and your quality of life. And again, help plan appropriate interventions, whether it's therapy, whether it's medication, whether it's something else. We can help with that. And again, the final role of the neuropsychologist in the surgical workup is to do the functional MRI, is to do the Wada testing to make sure that that cognitive function in your brain is mapped out as carefully and as delicately as possible so that if Dr. Ettinger and Dr. Snyder and the rest of the team determine that surgery is appropriate, that there is limited to almost no post-operative issues and post-operative deficits, or if we think that there may be, we can tell you almost very, very closely what we expect to occur, and you can balance that against the risks and the benefits, obviously, of doing the surgery to help cure or to help minimize the seizures that you have. So that's the role of the neuropsychologist, and obviously I integrate my findings and everything I do with the team itself.
What are your thoughts on brain cell regeneration if seizures are controlled eventually? And the other, which is why I came, cannabis.
Okay. Well, perhaps I'll ask Dr. Klein to talk about the issue of nerve cell degeneration, potential risk of memory deterioration in epilepsy, be it when one has uncontrolled seizures and when one has.
So if I'm going to answer the question, let me clarify exactly what you mean by regeneration.
Like some people have a stroke and then their brains can heal from the stroke.
Okay.
And regenerate. I don't know if that's the right word.
Okay. Well, the answer, regenerate can theoretically be used. Often what happens in a stroke is that while there is recovery of function, it depends. Sometimes there is recovery of the area of the brain itself. Oftentimes other areas of the brain just pick up the slack. So in epilepsy, it's not really exactly the same as the stroke. There can certainly be damage to the tissue, as Dr. Ettinger would agree. If the seizures stop, can there be recovery of the function that is impacted by the seizure? Yes, certainly that is the case. The analogy to stroke is a little bit different simply because in epilepsy, it's not usually an acute event that causes a real major issue, and therefore when, in epilepsy it's kind of a slow process over time, but certainly if you're having a deficit in a specific area and the seizures are cured or stopped or significantly reduced, certainly that area of functioning, whether in some cases memory, in some cases speech, can get better. It doesn't always, it's a very variable question, but yes, it theoretically can.
Okay, so certainly the topic of the potential beneficial effects of marijuana for seizures is a very hot topic now. And some of you may have seen a documentary on television talking about a very dramatic response for a child afflicted with a type of epilepsy called Dravet syndrome, which is what's called a catastrophic epilepsy because it's so devastating and associated with progressive loss of brain function and horrible seizures. In fact, we have known for quite a few years, mostly on an anecdotal basis and perhaps through some studies in basic science with rats and mice, that there could be some potential beneficial effects of marijuana against seizures. Why didn't I prescribe marijuana for my patients 5 years ago? Beyond the legality issues, we really had very little data. And marijuana, as it was always available, is a very unregulated environment. And so much of the marijuana that is out there that would be available to our patients would be potentially laced with other substances. And the marijuana itself has multiple components to it. There's a lot of exciting research now being pursued to try to further identify and focus upon those components of marijuana that may have the beneficial effects. We still have some room to go in this direction, and I would give you a very strong cautionary note that I would strongly discourage the idea of leaving this symposium and going out to the local dealer on Hempstead Turnpike and asking for a joint, because this is not, this would be fraught with many dangers. But I will say that this is an exciting time, and we are really looking for additional therapies, and I think this does offer some potential promise. And maybe we'll take one more question.
Who is doing the research in New York on this? Is somebody-
There is, in fact, a pharmaceutical company that we have been in touch with, and a lot of the focus has currently been on children, but there are a number of different groups that are starting to look, and don't be surprised if you'll see on our website that we soon will be investigating this, but it has to be done rigorously, scientifically, and not just jumping to a therapy. Okay, Melissa, we have another question.
Do you accept Medicare and Medicaid, and how soon can a new patient make an appointment?
This is a very specific question about the practice, and the answer is that we find a way to see everybody that is afflicted with epilepsy, that needs answers and needs additional help, and it's always our privilege and honor to help anyone in distress over their epilepsy.
Is there anything down the road going on right now with epilepsy and stem cells? Stem cells might help epilepsy somehow. Is there anything in the works going on for that?
There is indeed some research underway, but we are, in that particular area, we are very much still in our infancy. But I think this is yet another area that deserves some attention. Unfortunately, we're not anywhere close, I think, to offering anything of that nature. And there are a number of caveats in the use of stem cells, particularly in epilepsy as compared to some other disorders where there's more of a distinct loss of brain tissue. And, but I think, yes, this is one of many exciting areas that needs to be examined further.
Hi, I have two questions. One for you, Dr. Ettinger.
Yes.
Are there any new promising medications that are coming out for epilepsy?
There are indeed, and I am literally, at the end of this symposium, jumping in the car and joining my colleagues in beautiful, warm, sunshine, New Jersey, to meet with colleagues from across the country where we're meeting to discuss one of these new promising anti-epileptic drugs. There are indeed some new agents, even now FDA approved, but the problem is that even with the newer medications, we are not yet making a dent in the approximately 30% of individuals who, despite our best attempts with medications, are still having uncontrolled seizures. And that's where the role of Dr. Snyder is so important. And I think where we are really making some very exciting advances is in the area of the neurosurgical techniques and the neurostimulation techniques, and perhaps I'll ask Dr. Snyder to elaborate upon some of these.
Thank you.
I have a question for Dr. Snyder, too.
Just in very brief, again, I think the resective procedures for epilepsy have been very well established. When we can safely cut an area out, we can do that, and we can do very well. The things that we are refining are minimally invasive ways of taking that same tissue out and using techniques when we can't safely do those operations. So neurostimulation truly doesn't actually stimulate the nervous system in general. So vagus nerve stimulation probably doesn't stimulate anything, nor does deep brain stimulation, nor does responsive nerve stimulation. Now, it involves putting in a current of electricity through, but usually it inactivates a region. So if through stimulation we're inactivating areas, well, what's the advantage of that is that this is non-destructive ways of shutting down or temporarily, quieting areas of the brain. So again, with the model idea that epilepsy may be sort of a wave of electricity spreading through, if we can halt that wave, we can halt a seizure. So again, the most exciting one, I think, is something called responsive nerve stimulation, or NeuroPace, that involves putting wires in almost anywhere, but in specific areas of the brain to try to halt seizure progression or halt seizure development.
My other question is actually for you, Dr. Snyder. For example, say if somebody had a corpus callosotomy a few years ago, maybe a little further, maybe 10, 15 years ago, how far have, I see that there's a lot of mapping involved now. Has it become more advanced compared to the recent years where there are less likely complications related?
Well, so the question is, if someone had a specific operation to sever the two hemispheres in the brain, over time, has that surgery gotten better, I guess? Well, there are risks there are complications associated with disconnecting the hemispheres, and there are complications associated with the surgery to do so. Those are not necessarily the same, if you follow what I mean. I think our surgical techniques continue to improve. We can use the microscope, we use image guidance, we have better things to get hemostasis, we have better nursing care, we have better ICU care, etc. So in terms of that, yes, absolutely, those surgeries, like any surgery, have gotten safer. Well, there are certain risks and complications of separating the two sides of the brain. We may have gotten better at predicting who will suffer those complications, but the disconnection of the hemispheres is going to still be the same result in the end. So there are certain things that may be unavoidable, but perhaps our counseling has gotten better.
Well, it sounds like the mapping will actually help a lot avoid some of those problems.
So corpus, without going into every detail, corpus callosotomy is a non-destructive procedure, and there's minimal mapping that typically needs to or can be done for that beyond establishing the hemispheric dominance for different behaviors. So people that have something called cross dominance, but this was pretty well aware 5, 6, 7 years ago. People that have cross dominance, something where there's certain things on one side of the head and certain things on the other, are not good candidates. But we don't need to specifically identify very specific areas of the brain, nor in 2014 would that help us with this operation specifically.
Thank you.
Could you have more than one neuromodulation type of device in you, or it's just like one?
Yeah, I mean, you could.
Connections, it doesn't you don't get HBO or anything from that, or?
No one receives any television or radio. But again, all these procedures can be used in separately or in some combination. There may be times where we would say we're going to do a resection of one area that's safe, but the seizures may spread to an area that's not safe. And we may say, well, we'll take out the safe area, and then we usually might say something like, well, let's wait and see how you do. And then if your seizures return, recur, persist, we could think about something else. Would that be brain stimulation? Would that be responsive neurostimulation? Would that be, vagus nerve stimulation? Yeah, so we do, belt and suspenders when necessary is totally reasonable. Oh, I'm sorry.
Sorry.
Okay, I'm not, she's in charge, so.
I just wanted to know if there's a minimum age for a patient to be considered for surgery.
In fact, there's a minimum age that I personally operate. I don't do pediatric neurosurgery, but in fact, many of these operations are done on infants and at times even neonates, depending on the exact situation. So not at all. It depends on the actual disease, the progression of the disease, and the natural history of the disease. Some seizures, on the other hand, get better with age. So despite how refractory they may or may not be, they may not be someone we would operate on. But there is no absolute.
Right. Would you like to comment on the other side of the spectrum, the age spectrum?
On how is there anyone too old to have surgery? Well, the answer to that is that we don't count anyone's rings, so to speak. It's not like, oh, you're 102 years old. It's about functional status. We're going to be pretty disinclined to operate on people for anything, and you should be weary of anyone that wants to do much to your grandmother, great-grandmother, etc. If they're in a nursing home with a feeding tube, they haven't walked in 10 years, and they have severe heart disease and cancer. You'll find people that will operate on people like that all the time. And I'm not saying there's no indications, but certainly it has to do with functional status. There are 90-year-olds that are extremely healthy these days. And while we may not embark or be excited about 3-stage, multi-step epilepsy surgery, we may still think about a vagus nerve stimulator, or we may think about a single operation, depending on what we think we can accomplish and where they are. If that person's on the links every day playing golf and doing very well, they may have 10, 15 years ahead of them, and we're going to take that person very seriously.
I wanted to ask Dr. Klein, more or less. What if you have like a temporal lobe lobectomy, or you remove like a lesion on the? Do you ever find that there are people who have personality changes, or is there a higher incidence of anxiety, depression, or anything of that sort that you've come across?
So that's an excellent question. Most people ask it from the memory standpoint, which is what So I can address both. The answer is, I'll answer the memory first. The answer is, from the memory, yes. There can be some change in memory and cognitive functioning depending on which temporal lobe is removed, depending on which hemisphere or side of the brain is dominant for the patient. Yes, there can sometimes be a memory change. There are a lot of factors that are involved, but obviously that's one of the reasons why we do all this testing. We can always make you aware of that risk. There can sometimes be changes psychiatrically as well, but Doctor, I'm going to pass that off to you to answer. Yeah. Well, go ahead.
So one would think that if you have suffered from epilepsy, devastating seizures all your life, you have a curative surgery, you should become immediately happy. Wouldn't that be the natural thought? But in fact, it's much more complicated than that. For one thing, in a very strange way, individuals' lives become very used to having seizures. And one gets, and there's a lot of expectations on people. You've had surgery, now get on with your life. That's not so easy. But there are also electrical changes and chemical changes that occur after surgery. And we are well aware, and we watch out for what tends to be a very temporary risk of developing counterintuitively more depression after epilepsy surgery. But the good news is it tends to be very temporary, and then after weeks tends to abate, and then adjustment kicks in, and ultimately individuals who are seizure-free, depression tends to really diminish substantially.
Dr. Edinger, do you know of anybody with epileptic taking medication that have gone to a acupuncturist?
Okay.
And would you suggest it?
So one very important aspect of seeking any treatment is being open to all sorts of treatment possibilities. And there have been a number of studies looking at the value of treatments ranging from supplements, herbs, dietary changes other than the formal ketogenic diet, which I'll talk about subsequently, and chiropractic interventions, acupuncture, relaxation therapy, music therapy. While there occasionally are some reports about some value, the overall, the value of acupuncture sporadically has been found to be perhaps of value, particularly for the associated anxiety that may go along with epilepsy. There's not much very strong evidence to suggest acupuncture will make a tremendous difference. I don't see much risk associated with it, and I don't discourage my patients if they want to seek the treatment. Where I am more cautionary is if my patient says, Dr. Edinger, I want to stop all my anti-epileptic drug therapies because I want to do acupuncture. Where I'm also really putting my foot down is when my patient says, you know, I'd like to try some neck manipulations from my chiropractor to see if that would help my epilepsy. There's a situation where not only do I feel it wouldn't be helpful, but there are potential very devastating risks, including reported strokes in such situations. So it's those kinds of situations we want to really strongly avoid. Okay.
I just wanted to ask Dr. Klein, sometimes at night when I have a seizure, the next day my family says I talk very slow. Is that common, and what would cause that?
I mean, that's not, the answer is yes, it is. It certainly can be. That's not specifically a neuropsychological deficit necessarily. That's more likely due to the post-ictal state that you're in. And that post-ictal state can take a varied forms. One of them, in some cases, can be, word finding difficulty, slowness in thought, some increased memory changes, which usually kind of comes back to baseline levels as you get further away from the seizure itself. Yeah.
I have a two-part question. The first one is for Dr. Ettinger, and that is, do you prescribe midazolam? And the second part of this same thing is that I noticed that when my son has a seizure, he's now going to the freezer, and he puts his head in the freezer and breathes in the cold air, and it seems to slow down or stop the seizure. Have you ever heard of anything like that?
Okay, so I'll address your first question. Midazolam is a medication that falls in the category of medications called benzodiazepines. And there are a variety of benzodiazepine agents that we will use. One situation is use of these medications acutely, and if a person comes to the emergency room having had a cluster of seizures, don't be surprised if a drug like Valium or Ativan is administered, because it tends to either stop the seizure and it may reduce the chance of another seizure occurring. There are some benzodiazepines available that may be used on a more chronic outpatient basis, and some of these medications are showing some promise to reduce the chances of having more seizures. So yes, this does fit within the overall category of drugs that are sometimes used. Sometimes if a person has had a seizure, a benzodiazepine can be administered not orally because that person can't take a pill at that time, but sometimes seizures can be stopped with an intrarectal administration. So there's a medication called Diastat that's in children especially may be treated with that. Now, with regard to your second question, I have not encountered an individual who's had that specific technique to try to reduce seizures. We certainly know that in children there's the entity of febrile seizures, and sometimes interventions involve reducing the fever, so I might speculate maybe there's some kind of relationship to that aspect. But for my adult patients with chronic epilepsy, I must share with you that running to the freezer is not something I actually have ever heard among my patients. Okay, Melissa, I think we have another question.
I think I could try. I think I could try to explain the freezer thing.
Okay.
There's a little unusual manifestation, but for me, I get the way I know if a seizure's coming, I get very hot. So if I wear layers, I try it. But maybe that's the reason they have the thing with the freezer.
Out to the back step and breathes in deeply the cold air.
So it counteracts because you get hot when you tell an aura, and that counteracts and sometimes goes away.
It's an interesting theory, maybe trying to get relief from the symptom that one has.
Okay.
Other questions? In the back, we have Melissa.
Been seizure-free for a couple of years.
I'm sorry,
If you've been seizure,
very loud.
I'm
That
sorry.
is not broadcasting any sound, so you have to really speak up.
If you've been seizure-free for like 2 years, and then for your antidepressant, you have Lexapro, and then to switch to, I have to look, Zoloft, which is a 50 milligram one. Does that affect like seizures?
Okay, so let's talk a little bit about depression and epilepsy. The first concept is that for many years, many physicians looked at having depression and epilepsy as simply having a reaction to having any kind of tough chronic illness. And I recall even an epilepsy specialist years ago whispering to me at a lecture, boy, if I had epilepsy, I'd be depressed too. Isn't it as simple as that? But it's not as simple as that. And epilepsy and depression are linked in so many ways, biochemically, electrically, the medications we use to treat epilepsy, some of which can promote depression feelings, and so many other things. Then many doctors were afraid to treat depression because they said, oh, wouldn't the medication I use to treat depression lower the seizure threshold and cause more seizures? And while there was indeed an older generation of antidepressants, which we don't use very much anymore, called tricyclic antidepressants, had a very low risk of promoting seizures. In fact, the newer generation of drugs, like the Zolofts and the Lexapros, if anything, there's even some soft evidence to suggest not only do they not lower the seizure threshold, but they may even have some degree of protective effect against seizures, believe it or not. So it's very important that clinicians be open to the idea of treating. Now, with regard to the issue of one agent versus another promoting seizures, we don't have much data in that regard, but I would say if your physician feels that one antidepressant would be better for you for other reasons than another, I would have very little concerns and worries about seizures kicking in because you switch from one to another. Other questions?
Do you find that patients that have had epilepsy most of their life tends to get worse as they it's okay. As they get older?
So I'll start answering this question, then I may give an aspect of this to Dr. Snyder.
Okay.
We might have thought years ago that having a seizure, unpleasant, but sort of a nuisance, but not much concern that there are complications of the seizures. But we've realized over the years there are just so many potential complications to seizures, and that allowing seizures just to go on isn't just allowing something that's a bit of a nuisance. So many potential complications, the alteration of consciousness, the risks of injuries, and the risks of sudden death in epilepsy is a topic that we doctors, we've been very reluctant to talk about this issue. And we don't really know the mechanisms of it. But in fact, for severe ongoing seizures, there's the risk that one day of finding that a patient with epilepsy is found lifeless. We can't just say we'll tolerate some seizures. We need to be very aggressive about trying to knock out these seizures. Many other potential complications. We believe there may even be, over time, allowing severe seizures to go on, potential effects on memory, and Dr. Klein could speak about it. And then over the course of years, yes, indeed, sometimes we do indeed find that seizures that were relatively more subtle in the past over time can become more severe, more frequent, and so forth. But I'll let maybe Dr. Snyder talk a little bit about, again, the surgical interventions that might be indicated for different types of seizures, and Dr. Klein about the neuropsych complications.
I think just to stick a little more to your question, in terms of surgery and time for seizures, well, I think there's several questions. Well, obviously, on one hand, younger people in general still are healthier, so we're not rushing people to the operating room, but it's better to do these things when when the ducts are in line before other medical illnesses get in the way. Another issue that is still debated, but is something we think about a lot, is the propensity of seizures in one area to cause other areas of the brain to be more prone to become involved in these seizures. So, long-term seizures may actually make the brain more excitable to further seizures and may involve second areas of the brain for further seizures. And the other thing we know is that seizure surgery, maybe because of these reasons, the outcomes are better in patients that present earlier. So over time, again, there can be increased scarring in the brain. The areas, the pathways through which seizures spread most rapidly can become expanded. Now, this doesn't happen like a tumor spreading. It's more scarring that makes areas more prone to cause seizures, but over time, those areas may become expanded, and that may contribute to higher rates of failure in patients that have, epilepsy for 20, 30 years before they're operated on.
Yeah, and from a cognitive standpoint, yeah, absolutely. I mean, if you have, like I said, one of the risk factors for cognitive impairment is the longer duration that you've had the epilepsy. That's especially true if it's a generalized epilepsy syndrome where it's affecting large parts of the brain. But what the recent research over the course of the past few years has identified is that even patients who have focal seizures, meaning seizures only originating from a small part of their brain, even if those seizures don't generalize and don't cause a grand mal seizure, that other parts of the brain are getting impacted from a cognitive standpoint. And the etiology is not yet very well understood, but it seems that even if there's a focal part to the epilepsy and it's not spreading, that over time you can have impact in cognitive areas that are not directly related to that one specific focus. So yeah, again, the earlier the better from a functional standpoint as well.
As the medications control that focal type of a seizure, do we still have the threat of other parts of the brain becoming more affected?
You're saying from a cognitive standpoint, from a thinking standpoint, or just in general?
Well, just as long as there's seizures, it's always getting worse. It's just the question is whether or not it's affecting any other part of the brain if the medications have closed that aura.
Yeah, and sometimes from my standpoint, we see that a lot, and that sometimes I have to talk to Dr. Edinger, is when a patient comes in, there is a balance between the amount of medication you're taking to control those seizures and the effect that has on long-term cognitive function versus the effect of the seizures themselves long-term and on cognitive function. It's not an easy thing to answer, unfortunately. You're caught between a rock and a hard place sometimes, but in general, the seizures over time are thought to be worse simply because they can affect both cognitive function and overall medical health and risk to your safety, whereas the medications themselves can impact cognitive function, but usually not the other areas.
We've talked about depression and seizures being comorbid, and you mentioned that you assess certain risks. Dr. Klein, I believe, said specifically. Do you do the treatments, and what kind of treatments are available, or is it just simply a referral to a psychiatrist?
So the answer is I don't treat directly, but the assessment of depression in epilepsy is somewhat more complex than the assessment of depression in somebody who does not have epilepsy. So whereas in many cases a primary care physician can just say, okay, based on what you're telling me, we can just start an antidepressant. You don't always have to go to a psychiatrist. It's not always that complex. In the case of the seizures, it is more complex because we really want to figure out what is causing that depression. Is it only due to the fact that there are other psychosocial issues going on, including your health? Is it due to possibly the seizures itself or the location of the seizures itself? Is it possibly that middle between the seizures, sometimes that mood gets changed, an interictal type of mood disorder? That becomes a little bit more complicated, and both myself and Dr. Ettinger can certainly assess that and then make the appropriate recommendations, whether it's psychotherapy, whether it's psychopharmacology or medication, or changing the current medications that you're on. Those are the areas that are available. The treatments themselves for depression and epilepsy are the treatments for depression in general. It just has to be diagnosed appropriately as to the etiology or the cause so that it is addressed in the correct way.
I actually had a grand mal seizure in 2004, and I knew what led up to it and the auras I was feeling. And recently I was experiencing those auras again. And now I was diagnosed with these focal point seizures. How often do focal point seizures lead up to grand mal seizures? Because I feel like those auras I've had, and I've been experiencing them recently again, I'm afraid I'm going to have a grand mal seizure. I don't know if that's more like a question or a statement.
So, naturally, it would be very difficult to answer your question very specifically without really being your healthcare provider and knowing all the details. But I would say that if you have developed a recurrence of focal seizures, auras are indeed seizures. They're not just warnings for seizures. They are seizures. And if things have developed now, this is something very important to bring to your doctor's attention, and it may warrant some additional EEG testing and other interventions, and to really pay close attention to what's happening. Okay. Yes.
Is VNS therapy still a viable option as it was years ago, and are there any long-term risks with being on it?
Okay.
In short, well, yes, it's very viable. I mean, it's something we do all the time. And it works very well. It's imperfect. We don't consider it a curative procedure, right? It's a palliative procedure. There may be a small subset of patients that are seizure-free with vagus nerve stimulation. But in fact, it's one of the only things I'm aware of in anything I do for anything that gets better with time. So almost anything we do for any disease over time, people don't do as well with it. Vagus nerve stimulation, if you've had it for 5 years, it works better usually than at year 1. And the further out we look, the better. There are no risks that are increased with longer-term use of stimulation. So there are small risks of hoarseness associated with stimulation. Ironically enough, I have to cough. Or a little, it's, the power of suggestion. But, or a voice change while the electrode is firing. There are, tiny risks of other things happening. The battery, of course, needs to be replaced. But beyond that, this is a very, very safe procedure. It's something we think about very quickly in people that aren't candidates for any surgery. And it's something we sort of hold in our back pocket for people that are, and use it as an adjunct when necessary.
Does the battery have to be replaced only if it's not working, or?
Well, like any battery, eventually it will approach its end of life and need to be replaced.
Okay.
I had a question for Dr. Klein. You talk about depression and epilepsy. And a test, you say you have to know if the epilepsy is causing the depression. And I'm kind of having a hard time understand how you can separate the two, because I feel when you have epilepsy, first of all, you find that there's a lot of things you can't do anymore. You're out of work, you can't drive, you can't do this, you can't do that. Right. So that in itself can cause depression. And how can you separate that part from the seizure part? I don't fully understand.
So the answer is, first of all, we don't always have to separate it. Okay, quite often it's a combination of the two. It's not like it's one or the other. In most cases, it is both. The fact that somebody has seizures does make them more prone to having depressive symptomatology based on just, again, the location of the seizures, the nature of the seizures. But at the same time, obviously, life changes occur in somebody who has seizures, and that causes your standard, quote unquote, depressive reaction. So the goal is not always to distinguish. When I talk about distinguishing, sometimes it becomes important from Dr. Ettinger's standpoint, because the medications that you're taking yourself, that themselves can trigger mood reactions. Sometimes it may be the seizures themselves. And again, that's going to depend. That's just going to be differentiated based on a good history, good questions. If you started taking a new medication, you went up on the dose, and suddenly you noticed a change in mood without any any major psychosocial changes in your life, well, that answers one thing. If you kind of have a vague, low-level depressive symptomatology overall, and then certain things trigger it, well, that might be a different reason. So the goal is not always to separate it. The goal is to make sure that we know what the etiologies are so that they can be addressed appropriately. But certainly they can be comorbid. That's not a question at all. Absolutely.
I'll just add one other comment. Certainly our research and those of some other distinguished researchers have shown that, in fact, epilepsy is not just a risk factor for developing depression, but depression is a risk factor for developing epilepsy. So, and it's not that depression causes epilepsy, it's more likely that depression and epilepsy go along together and that there's some common underlying disorder that may show itself with depression or with epilepsy or with both, and the timing may be quite different in different individuals.
Is there any correlation between epilepsy and pain or spine disorders? Let's say scoliosis, migraines, those sort of things.
So I was involved in a perhaps the largest epidemiologic survey of conditions that go along with epilepsy, and among the list was pain syndromes. So pain is indeed something that has elevated risk, and there's so many different aspects you could speculate, different types of pain. Headaches are very common. Migraine itself has an elevated risk, and post-seizure headaches are very common. Then there are all sorts of complications of seizures, unfortunately, even as dramatic as injuries, fractures, and so forth. And then there are many other potential complications, risk of osteoporosis from some of the earlier medications we used to use for epilepsy, and bone complications. So you can imagine, indeed, there are many potential risks.
I have a question for Dr. Snyder. Is it common for after a vagus nerve stimulator surgery to have your left vocal cord to be checked over? Because I had to go to my ENT doctor. He says my left vocal cord is out of place.
You know, the vagus nerve is the nerve that provides innervation to the vocal cords, as well as running back up to the brain. So it runs from the brain down through the neck. So in some number of patients, there may be some amount of disturbance with the vagus nerve. I'm not sure that it's extremely common to have that exact problem, but nor would I say that that's something that I've never heard of.
Oh, okay.
Any other questions?
This is in terms of emergency response medications. What's the prognosis on sort of like the EpiPen kind of emergency response to seizures, to lengthy seizures?
So in the past, if one had a seizure, one would be waiting for the ambulance to arrive, and then the ambulance might bring an individual who's having ongoing seizures to the emergency room, and a lot of time is transpiring. So there have been some studies suggesting that use of medications in the field could lead to a much better rate of getting the seizures under control. We do believe that seizures going on in itself may be a poorer risk factor for better prognosis. So there is indeed evidence to suggest that sooner interventions, and the intervention you mentioned is just one of many that could be considered to try to abort the seizures. I think we're hearing one or two more questions. Yes, please.
Just following up on her question, I was wondering, my son uses the Z midazolam, which we haven't had to use yet, but it's the nasal spray rather than the diastat.
Right.
The only thing is that I can't get it here. I have to go call a pharmacy in New Jersey. They have to mail it to me. It's not supposed, just like an EpiPen, it's supposed to be kept between like 58 degrees and 86. Now we had cold temperature. They're mailing it to me. I'm concerned it's breaking down in the 0 degrees. So why don't we have pharmacies here on Long Island that sell this item?
So I personally have had discussions with one pharmaceutical company that is working to make the availability of that particular product more available. The wheels of approval of medications by the FDA turn slowly in this country. There are agents available elsewhere. There are sometimes commercial reasons why certain companies here are less inclined to invest all the money that's needed to get the data that's needed to get FDA approval. It's a very complicated story, so it can indeed be very frustrating. And trying to get medications or treatments from abroad is unfortunately not an uncommon story, and is something we have to work with. Okay, I think we have time. I want to give time for someone who hasn't asked a question for our last question. Yes, please.
For a person like myself, I have a serious head injury 31 years ago when I was an undercover police officer. I have done a balance therapy program where they measure your balance for vestibular, disequilibrium. Would that make the seizure beneficial or not?
I'm sorry, so your question is, would
I have balance.
Therapy for balance
Yes.
difficulties be helpful for the balance or for seizures?
Or would it make seizure worse, or would it be beneficial?
I would say I would see no evidence that getting therapy to enhance your balance would have any risk of lowering the seizure threshold, and I would encourage you to get whatever therapy would be available to help you with the balance difficulties. I would mention parenthetically that we all know that the medications we use to treat seizures and control seizures that can occur as a result of head trauma themselves can lead a person to be more prone to imbalance. It's very important to remind your doctor that your balance difficulties, unsteadiness, and so forth may in fact be a result contributed to by your medications, and sometimes revisions in medications should be considered so one has a better quality of life with regard to those problems. Okay, well, I want to close at this point and tell you how delighted we all are to have had this opportunity to meet with you, answer your questions, and we're always delighted to provide additional services, try to answer your questions, meet with you if you would like in one of our numerous offices across the area. And again, a special thank you to Mr. Tom Hopkins from the Epilepsy Foundation and his staff, who are also wonderfully supportive to the epilepsy community. Thank you.